So it gives me great pleasure to introduce Don McIntosh, who I've known probably for 20 years now. Don has done some inspiring things leading the training program in Canada, and I know he is a strong advocate of a patient-centered approach to endoscopy. Don, thank you very much.
Thank you very much, Roland. I'm going to go through a best practice and sort of patient journey. And the idea when I was given this topic was really thinking about patient-centered approach, which is certainly words that we hear all the time. So what I'd like to do is just sort of very quickly give us what exactly are the things that we think about in terms of a patient-centered approach. I have no disclosures that are relevant to this topic, and the objectives are to review the elements, as mentioned, of this approach to endoscopy. So you need a scope. Patient hears these words, and the reaction certainly can be, I think, sometimes quite exciting. This gentleman on the right, rolling around on his carpet, on the left rather, is not excited about having an endoscopy, and the doctor may be quite excited about the ability or the opportunity to do this. The journey starts. So I guess the first question is really, is the decision appropriate? And you need to think about, is this procedure being done for the right reason? And will it be done in a timely manner? You have to remember that when a patient hears the words, you need an endoscopy, this is anxiety generating, particularly if, for example, the indication is something like a positive fit, where now everybody, well, many people would think automatically, I've got bowel cancer or I have a high risk of cancer, and then being told they're going to have to wait for 3, 4, 5, 6 months. Obviously, this is not it doesn't make the patient happier or satisfied. Patient needs to be informed of the procedure appointment time and location. This really should be done in writing so that it avoids confusion and issues about no-show. Consent is very important. Obviously, different jurisdictions have different legal aspects in terms of consent, but there are certainly various themes that are consistent. One, the patient obviously needs to be informed of benefits, risks, and alternatives. And alternatives includes not doing the procedure. Not only is it what other options, how could I investigate the question or the problem, but maybe not even doing the procedure. And that should be mentioned. There has to be an opportunity to ask questions, particularly if you're doing direct-to-procedure investigations where the patient is seen for the first time, often in the endoscopy room. So the patient needs an opportunity. They need to be provided information. They need an opportunity to answer questions or be able to ask questions that need to be addressed beforehand. And patients should really be provided with written information, which should be available in their language. And this is important. In Canada, it means it has to be French and English, and obviously other languages as well, depending on the local community. Check-in and prep. Privacy is paramount. You don't want to see an endoscopy room full of bodies like here, waiting to hear the story and see what's going on. You need to have a change area. Lockers for personal effects really should be provided. Health review and IV access is done privately, and a waiting area prior to the procedure needs to be done privately. Be private and not mixing with patients who have just had a procedure. The procedure itself needs to be a high-quality examination. This means taking the time required, because at the end of the day, we're doing the procedure for the patient, not for ourselves. This includes appropriate sedation, which has a discussion ahead of time about what is appropriate sedation. And it also means that you actually need to discuss the possibility of no sedation. I've often had patients say to me, if I'd known I didn't have to have sedation for a procedure, I would have gone without. So that needs to be thought about. Post-procedure, I think patients should receive written communication before leaving the unit. They should include things like results, whether further investigations are required, what is the planned follow-up, is it another colonoscopy in 3 years or what have you. When do we restart medications, particularly relevant things like anticoagulant agents, and are there travel restrictions? For example, if I've done a large EMR of a patient with a big polyp, should they be flying in an airplane across the Atlantic Ocean in the next 4 or 5 days? The picture on the right shows a car. I don't understand the concept of you're going to do a scope and then you'll see the patient in 6 weeks to tell them the good or the bad news. You certainly don't wait for your car mechanic report. I've yet to have an automobile mechanic tell me to come back in 2 weeks to tell me what was wrong with my car. So we wouldn't accept this, and I don't think we should expect our patients to accept this either. Post-procedure, as mentioned already in the recovery room, there really should not be mingling of patients who have just recovered with patients who have not yet had their procedure. And very, very important, I think instructions need to be provided for post-procedure, potential post-procedure problems, such as what to expect, what discomfort or what other issues might arise, what to do if problems do arise, and who to contact. And patients should be given a contact number, not just call Emerge or call whatever. They should be actually provided the information, who and how they should be able to get help. Finally, if there's bad news, you need to use a private room. If your endoscopy unit doesn't have a room, you need to have some kind of a facility where you can take a patient and their family to have this conversation. I've seen things in Halifax where I work where prior to having a private room, we had occasional person giving news in the waiting area in front of other patients and family. Obviously not appropriate behavior at all. Post-procedure, there needs to be an opportunity for complaints and feedback. Patients need to be able to give feedback on how you did, whether that's a survey, a regular survey. The idea here being is how can we improve what we are doing to improve the experience of our patients? Likewise, not just feedback, but if a patient has a complaint, they need to be able to provide that information. So some kind of a system has to be set up for this post-procedure.
So I think you're not alone, your unit's not alone. We still have that in the UK, and so I think this is a problem that we all face. So actually it's just thinking about what systems and structures can we put in to get the best out of the team. So what I thought we might do is talk a little bit about an adapted briefing for this particular session. Now there are lots of us in the room, and I just thought what we might do is a mini briefing session, if that's okay, just to illustrate the concept and to think about how you might adapt this for use in your unit. So my name's Monique Mathrew. I'm visiting faculty. Thank you very much for having me. And I'm a gastroenterologist with an interest in endoscopy and patient safety. So maybe if we could just introduce ourselves and what our roles are, it might make the briefing a bit more real.
I'm Linda Bells. I'm a gastroenterologist and currently a fellow in interventional endoscopy.
I'm Ewald. I'm a nurse, endoscopy nurse here. Voila.
I'm Thibault Leroy, also assistant here, gastroenterology, taking care of the patient in the room afterwards.
So Thibault, just if I understood that correctly, you're the patient advocate for this particular
room, yes. And we also have an advocate outside of the room who does the planning afterwards.
So that's particularly...
So we have two...
Mummy, if we could tell...
So we're with two assistants doing the patient management afterwards.
Sorry, I know we lost sound there for a moment, but Thibault was just explaining that we actually have two patient advocates. We're in a situation where we're doing live endoscopy, which, you know, we can sometimes get very distracted in what we're trying to teach, but actually the patient advocate's role is crucial in maintaining that patient safety and maybe asking, should we do this or should we not? Should we actually reassess? And I think that's a really important role. So thank you for being here. And we've got some people behind us that we can't quite see, but I don't know if they want to introduce themselves or if they could shout out.
Maybe I can do it for them because we won't hear them. But we have indeed an anesthesiologist who talks to the patient. There is a nurse that works with our anesthesiologist that also is with the patient when he goes to sleep, make sure there is an IV. So they are a team of two people. And then we have Ewald, who we mentioned, a dedicated nurse in endoscopy. And we have two backup nurses in the room who will help whenever we need something.
Fantastic. So lots of people in the room. I'm really rubbish with names, but I think there's a lot of evidence that shows that actually having people's names explicitly in the endoscopy room encourages closed loop communication, and it's easier to talk about an error if you know the people's names. So I don't know the anaesthetist names, I don't know the assisting nurses names, but actually I probably would forget. So is there anything that you might think of that would help you in that communication when you're in the heat of the moment?
So I think when we start the morning in endoscopy, we always go through, we introduce ourselves. We obviously, most of them we know, or I know by now, but if I don't know anybody and I think they have the same, we introduce ourselves, and that's how we usually do it. If we forget in the day, we obviously ask again, but we always have a badge where you can read the name in case of doubt.
Yeah, I think that's a really important point, having a very visible name so you can actually address a specific task to a specific individual. And we've adopted a practice recently where we pop the names explicitly on a whiteboard so that when you're in the room, if you can't see the name badge because it's covered in PPE, you can make a reference as to what's on the name. So names, introductions are a really important part of briefing. I had this issue just yesterday in one of my cases where a patient had a persistent tachycardia and the SATS monitor wasn't working when we were doing the checklist, and we put it back on, and actually this patient had a tachycardia that persisted to 130, and we actually pulled the procedure. Without that separate layer of check, I may have overlooked that to the patient's detriment. But separate to the individual safety checks, I think the checklist is more powerful because it has a role in minimising error. But really, I think its main powers lies with facilitating communication within that team. It builds a sense of team cohesion, that you're actually focused on the task ahead and that everyone's concentrating on that patient at that time. And it builds in this patient safety mindset of we're about to do something quite invasive, even though for us it's just a routine diagnostic OGD. For that patient, it's a serious intervention. And what about patient opinion? Well, some of my senior colleagues, when we were trying to devise a checklist, thought, no, it's not good. It's going to jeopardize the confidence. The patients will think we won't know what we're doing if we're doing all these checks at the last moment. And they'll become frustrated saying, shouldn't you already know this, doctor? I love this picture of Joy Tompkins, a grandmother in the UK, who makes her resuscitation feelings very clearly known on the front of her chest with do not resuscitate. But this is a belt and braces woman. She takes no prisoners. She double checks and she puts a PTO sign on her back. And what we did as part of our checklist implementation strategy is that we asked patients, what would you think about a checklist? How does it make you feel? And we trialed it. And actually, I think most patients strongly agree that they'd rather doctors would check again rather than assume knowledge. And actually, there's an element of it bringing patient empowerment. This quote, I think it's important to double check. It allowed me to remind the doctor about my warfarin, is really crucial. And I think when your patient's not sedated, you have that constant dialogue. It helps with managing their anxiety and expectations, as we've heard this morning. And also, the checklist is quite good at abolishing hierarchy. So actually it puts everybody on an even playing field. And as we talked about the briefing session this morning, actually making it explicit about the names in the room and communicating those to the patient as well, it actually allows you to target communications. So instead of just saying, can I have some Buscopan, please? You can say, Eva, may I have 10 milligrams of Buscopan? The heart rate is 80. Eva will give the Buscopan and say, Buscopan given, and actually it's practicing this closed loop communication. Similarly, if I'm about to make an error, it allows my team members to say, Dr. Mathew, did you really want to do the biopsy? Do you remember we talked about that? And yes, thank you for reminding me. So I think these elements of actually using all of the people in the room to give the patient the best possible care is something that we can put into practice with safety tools such as the checklist.
I'm very happy to help with advances in medicine, and I was assured that this would not affect my procedure in any way, as it was just recording what the endoscopist thought the polyps, what they were like, what they were. Sadly, I think this was not the case, and the quality of reporting was severely degraded in my participation in this study.
In what way do you think?
Well, reading the report after the procedure, it was fairly poor.
So we've lost.
Right, so missing information.
Missing information like?
Yeah. Oh, well, things like no scope identification number, no details of how the Buscopan was given, IV, not orally. There were also lots of spelling mistakes and typos, which showed a general lack of care and attention.
Okay, so not the greatest report. Was there anything else that was wrong with that, or?
Yeah, the findings were not fully described properly, nor were they cross-referenced to my previous procedure. There was no comment on the bowel preparation, which I thought would be useful given my issues of taking extended preparation previously. I also think the labeling on the photos as part of the research study was very confusing.
In what way?
Well, there are a lot of random letters, clearly a code for the research findings, but this wasn't explained anywhere. I found it very off-putting and frankly illegible.
And that wasn't sort of described to you or explained to you at any point either after the procedure or anything like that?